So I'm going to talk about the specificities of tobacco and other substance user, and why we think that there is a need for a unified harm reduction approach. So, sorry, I think it doesn't. Yeah. So now, what are the difficulties that tobacco and other substance users face? In fact, now what we already know is that the rates of smoking are 2- to 4-fold higher in people using other substances, and that also persons with substance use disorder are much less likely to quit. So I have some numbers here. For example, the quit rate among smokers with no history of psychiatric disorder or substance use disorder was 42.5%, which is quite high, but there were significantly lower quit rates which were associated with alcohol use disorders, like 17% or even less. Now, over 75% of alcohol and drug dependent persons in early recovery smoke cigarettes. And in general, they tend to be very heavy and high nicotine dependent smokers. Also, what has been found from several studies is that cigarette smoking increases the likelihood of relapse in people with substance use disorders. Now, just to confirm what I just said, you see here a graph of the prevalence of cigarette smoking in clinical samples of individuals with psychiatric disorders and substance use disorders. And what you see also, what is interesting, that although the prevalence in people with psychiatric disorders is already very high, now the prevalence in people with other substance use disorders is even higher. So you're being even more than 80%. Now, what's the problem in people with substance use? The problem also is just like in psychiatric disorders, that there are neurobiological modifications. In fact, that have been taking place due to the repeated substance use. And so what animal and human research has found is that there is a reward system dysregulation, stress system deactivation, and prefrontal cortex impairment. And all these factors, in fact, impact on the possibility to quit smoking. Now, a bit more on the relationship between tobacco use and substance use disorder. Now, what you have, just as in psychiatric disorders, there are intrinsic factors such as shared genes, abnormalities in the brain reward pathways that predispose individuals with substance use disorder to smoking. And what's more, you have a very high comorbidity with cigarette smoking in patients with dual diagnosis. So building on what Dr. Kandil just said, so in people with psychiatric disorder and substance use disorder. Also, people with psychiatric disorder, but also with substance use disorder, tend to use nicotine to self-medicate their symptoms. And also what has been found is that nicotine administration through cigarette smoking modulates several neurotransmitter systems, just like the dopamine system and the serotonin system, which is thought to be involved in the pathogenesis of substance use disorder. Now, what are the most frequent substances that are used with cigarettes, according to recent studies? But I could also extrapolate this to the context, like in Tunisia. So you have alcohol, but you have, above all, in Tunisia, really cannabis. And why is there this very frequent comorbidity? It's because tobacco and cannabis share common environmental factors and smoking cues that might really contribute to this sustained use. And also what has been found is that alcohol and tobacco use increase the cravings for one another, suggesting underlying biological and physiological mechanisms. Now, what can be done about it? And here's my advocacy for, in fact, a more unified harm reduction approach in the context of people who are substance use disorder, who have another substance use disorder, and who do smoke cigarettes. Now, as we all know, there have been harm reduction strategies implemented, and they have shown to be effective, especially in people who use injectable drugs and also people with alcohol use disorders. And in many groups, or especially subgroups of people, abstinence, in fact, has been replaced through these harm reduction strategies. And these subgroups of users are especially polydrug users. These are people with psychiatric comorbidities and socially and economically marginalized groups. And we think that people with tobacco use from these subgroups, at least from these subgroups, should benefit from the same type of harm reduction strategies. And this could be the use of snus or other oral tobacco products. As an example, in Tunisia already, and this was there's a traditional use also of oral tobacco products, which is called MEFA, and other harm reduction approaches could be the use of heated tobacco products or e-cigarettes. In Tunisia, the problem is, when I talk about especially people going to the public hospitals, so you have the socioeconomic levels, which is quite low, and which makes it very difficult for people, in fact, to buy e-cigarettes or heated tobacco products, and it's not something which is included like in any health insurance system. Now, of note, so for tobacco harm reduction, in fact, a partial substitution is generally ineffective. So substitution should ideally be complete and sustained for effectiveness. Now, to conclude, I would like to say once again that substance use disorders are very important contributors to the high rates of tobacco addiction. And smokers with these comorbidities demonstrate lower rates of quitting compared with smokers in the general population. Therefore, a unified harm reduction approach for both substance use disorder and tobacco addiction could therefore be an effective means to reduce risk, which are linked to both types of addiction.